very much, Hugh. Right, good morning, everyone. As I promised you, I was going to come and be your breakfast again. Unfortunately, you've got to listen to me again. So the title of the talk that was given to me is Trying to Fight Osteoporosis, and I think JK has set the scene very well about trying to fight it on both the resorption front as well as the anabolic or perhaps formation front. Not so much anabolic, but perhaps a little bit formation. So again, to put everything in perspective, the question that we need to ask ourselves whenever thinking of starting therapy is, how do I choose? And the choice would depend on these three factors. Proven reduction of fractures, proven sort of advantages in terms of improving the microarchitecture of the bone, and certainly not last, the important fact that it has to prove itself as a safe agent, because remember, this is a chronic disorder, patients will be taking it for years. So let's now examine, in terms of efficacy against fractures, a little bit more in-depth compared to what I talked about yesterday. When examining data, question about whether it is effective is not good enough. I want to know whether it's effective at all sites. I want to know whether it's effective fairly quickly after I've initiated it. And I want to know that it is sustained, this fracture reduction. And do not worry about perhaps the problem of atypical fractures if you've taken it for a long time. And as JK has also said, you want to know whether or not it's effective at the different categories of patients, in the early ages, at the older age, and issues like that. And do these drugs have any data to prove itself that in Asians it works as well? On top of the postmenopausal osteoporotic problem, which is, I understand, of course you recognize too, the predominant problem that many of us face managing patients, but don't forget the problem of steroid-induced osteoporosis, and this is male osteoporosis. Let's now look at this in more depth. You've seen this slide from yesterday, and therefore I'll not belabor the point, just to remind everybody that it is most of the classes of drugs that we have available have proven themselves in terms of reducing fracture at the spine. However, where there's no in spine, and specifically we're talking about the hip area, then you have three drugs that actually have only proven themselves, i.e. the bisphosphonates, then teriparatide, and strontium ranelate. Looking at the details of it, which I've mentioned to you, let's now review strontium ranelate, because that is part of the title of this talk and the reason that you are here. In the short term, after starting therapy, is it effective? Looking at this part of the graph, you will see that within the first year of initiating strontium therapy, you will see that there is already a significant impact on reducing fractures. We are talking about the outcome, the event itself, not improving BMD. And then 3 years, from 0 to 3 years, it continues to be effective. And from 0 to 4 years, you still see a sustained efficacy. In terms of long term, beyond many of the trials that you and I have seen, actually like raloxifene goes on to 3 years, bisphosphonates go on to 5 years. The question here is, does strontium ranelate have those long-term study efficacy as well as beyond 5 years? So now reviewing the 5-year data for their trials, you will recognize that for whatever site that we are looking at, that there is still significant fracture reduction out through 5 years of exposure to this drug. Whether it is non-vertebral, whether it's vertebral, and even hip fractures. So in the short term, it works fairly fast. You see an efficacy within a year. You continue to see the sustained fracture reduction out through 5 years. And what about longer? They already have 8-year data, which has been published, and you will see its effect on reducing vertebral fractures. This is the first 3 years, and you will see that from the first year through to the third year, you will still see that there's a cumulative incidence of about 11.5% reduction, and you will see that here, from 5 years to 8 years, continued reduction in fracture incidence when patients were continued on strontium granulate. Non-vertebral sites, very, very similar kind of numbers, sustained efficacy, no signal whatsoever to worry us that perhaps after a certain time you worry of whether or not you've actually made the bone too sort of like suppressed until you might in fact have problems with brittleness. Next, going on to different types and categories of patients. Let's look and focus on, dependent on the patient's age, whether they have data to confirm that yes, it is effective. On this side of the graph, you will see that these patients are 50 to 60 years of age, and you will see that long ago already, they've proven themselves that in the younger age group, they were effective at preventing fractures. And on this side is women who were elderly, above the age of 80, whether it's vertebral sites or non-vertebral sites, again, starting early on with fracture efficacy, through to 5 years later, still fracture reduction efficacy with whatever sites you're looking at. So in terms of ages of patients, there has been proof and evidence to confirm that it is effective at the various ends of the spectrum of patients who will require medication from younger to older. In terms of types of patients, whether they are osteoporotic, whether they are osteopenic, whether they're fractured or not fractured, this slide actually tells us that irrespective of disease status, there has been clear evidence established for the use of strontium granulate. So let me just take you through a little bit more in detail. This is osteoporotic women who have fractured going into the studies. Significant reduction. Osteoporotic women by BMD who had not fractured, again significant reduction. They have had an opportunity to study women who were osteopenic. Osteopenic by definition of BMD, better than -2.5, and in osteopenic women, by BMD definition, but having had fractures, so that makes her clinically osteoporotic, but certainly the evidence is that it is still effective at preventing future fractures. In women who were osteopenic and not fractured, again, significant success. Please recognize that these bars are very different in height, that the worst case scenario are the patients who are the most severely affected, i.e. osteoporotic, who've been fracturing, and you can see that if they were not treated, there's a 40% chance that they will fracture again. So please, whatever else you do not recognize the highest risk individuals, because even though you're talking about 40%, the absolute reduction and the absolute benefit is significant. So don't forget, these are the individuals that you should try not to forget to treat. Next, what about whether or not they fractured in the past? We understand again that BMD is not the sort of holy grail to determine risk of osteoporosis and risk of fractures. That if a woman has had a fracture, a low trauma fracture, then her subsequent risk of fracture actually is about several-fold higher than somebody with an equivalent BMD who has never fractured. So let's try and see whether the strontium granulate has proven itself in the highest risk individuals, i.e. those who've had more than 2 prevalent vertebral fractures. There was a significant benefit while on strontium versus placebo. But those patients who were osteoporotic but no precedent fracture going into the trials, again you will find significant benefit. So irrespective of risk, irrespective of whether they're fractured or not, there is fracture efficacy seen. Next, JK mentioned about over-suppressing these patients, worry whether or not you might perhaps be freezing the bone or making them adynamic. So let's look at whether baseline turnover might